Good evening, everybody, and welcome to tonight's Facebook Live event on lymphedema. My name's Ian Irving. I'm Icon Group's Chief Medical Officer and also a practicing haematologist at Icon Wesley in the Wesley Hospital in Brisbane. And we have a really interesting and fascinating session tonight talking about the important but often overlooked topic of lymphedema. Thank you very much to everyone who's joined. There will be a recording of tonight's session on the Icon Cancer Centre Facebook page. So please share the link and encourage people who haven't been able to join in tonight to be able to watch this session at their leisure. Tonight's topic, as I said, is going to deal with lymphedema, and we're going to go through the diagnosis of lymphedema, the treatment of lymphedema, and of course delve into some of the support services that are available to people with lymphedema. We've got two very experienced speakers tonight joining us to discuss lymphedema. First of all, we're going to hear from both of our experts, and then for the second half of tonight's event, we'll answer your questions. So please, if you have any question relating to the diagnosis, management, or support services with lymphedema, please ask your question through the chat function at Facebook Live. We'll try to get to as many questions as possible. As I say in all these events, please don't share too much identifiable personal information that deals with people's medical history, but of course, ask whatever you think is appropriate. And any question we can't get to tonight, we'll put the answer up on the transcript of the event later on, again on the Icon Cancer Centre website. I think we'll get started now, and my first task is to introduce our two speakers. First of all, we've got Professor John Boyages, who's an extremely experienced radiation oncologist with Icon Cancer Centres in New South Wales, in Wahroonga, Norwest and Gosford. John has extensive experience in treating breast cancer. He's become an international expert in lymphedema, has published over 200 papers in peer-reviewed journals, and is also a published book author on the topic of lymphedema. So, John, thank you very much, both for joining us tonight and also for being part of our Icon network as one of our radiation oncologists.
Thank you, Ian.
And joining myself and John tonight is Dr. Debbie Geyer. Now, Debbie provides a unique perspective on lymphedema tonight. Debbie is a practicing general practitioner in Cremorne in Sydney. She is very busy in her general practice work, but has also found time to be the Vice President of the Lymphoedema Association Australia. Debbie has suffered from lymphedema from an early age and gives the unique perspective of both being a medical practitioner with training across all aspects of health, including lymphedema, but also the perspective of a patient. And it is in that role and also her vice presidency of Lymphoedema Association Australia that brings Debbie to speak tonight. So Debbie, thank you so much for joining us.
Thank you, Ian. Thanks.
So that's the introductions done. Again, I thank everyone for tuning in and also our two speakers. We'll go into the questions now. And as I said, the first half of tonight's event, we're going to hear from our experts, and then we'll, in the second half, answer people's questions. So again, please put your questions through the chat function. I'm going to, first of all, go to you, Debbie. If you could please just tell us all, what is lymphedema?
Sure. So lymphedema is a chronic and permanent swelling of one or more parts of the body. And it's characterized by swelling, say, in the arms or legs, but it can even be in the head and neck or in the breast area or genital area. And I guess if you think about the lymphatic system, I want to think about it as part of all the circulation. And so arteries take the blood away from the heart and veins bring it back. But not all the fluid goes back via the veins. Some of it goes back via the lymphatics, and that's like the proteins and the infection-fighting cells. And so when the lymphatics isn't working properly, you might find that there's a buildup of this protein-rich fluid in the tissue spaces. And so essentially it's a functional overload of the lymphatic system when there's more lymph fluid than the actual lymphatics has ability to take away and remove.
Right, thank you for that. No, it's because it is a complex area and it's often misunderstood by various doctors who may not see lymphedema every day of their practice. Are there different types and causes of lymphedema?
Yeah, there certainly are. John, I'm not sure if you're wanting to elaborate with that or, yeah.
Yeah, I think Ian, there's what we call primary lymphedema, which is obviously what Debbie experienced at a young age. It can be diagnosed at birth or even before birth on an ultrasound. And of course, it's very distressing when you see young children with, and parents get very distressed if they see a swollen hand or foot or leg. And then there's secondary lymphedema. Now, I categorise secondary lymphedema as being benign or malignant. Benign is the most common cause for lymphedema, usually damage of lymph nodes and lymphatics due to surgery or radiation. But we do see it in trauma, in bike accidents, and we see it after varicose vein surgery. And I've seen a severe case after removal of skin after bariatric surgery. People lose a lot of weight, there's a lot of overhanging skin, and then plastic surgeons may remove that skin. But the most common cause is cancer treatment. And the second cause is what I call malignant lymphedema. Now, this is rare, but if there's any therapists listening to this talk tonight, if there's a new case of lymphedema associated with pain perhaps, or pins and needles, it's come on suddenly, don't always assume it's benign lymphedema. Always think, could this be a regrowth of the cancer or lymph nodes under the armpit causing blockage?
All right. No, thank you for that that tour through the different types of lymphedema, John. And we'll come back to you in a minute, John, to as we go into the treatment of lymphedema. But Debbie, before we start discussing treatment, you mentioned, and John has as well, swelling of the limbs as the telltale sign of lymphedema. Yeah. Could you expand a bit more on what should people look out for thinking they or their patient may have lymphedema?
Yeah, sure. So certainly some of the signs and symptoms, I mean, swelling would seem to be the obvious one given what we've said so far. But sometimes even before the swelling's visible, there can be sort of a heaviness in the affected area or limb. And some people will even feel like their skin's getting tight, because if you can imagine you're getting that swelling, that the actual skin on the surface starts to feel tight. And some people might notice, for example, that their jewelry's not fitting properly anymore, and with the lower limb it might be shoes not fitting quite as well, or clothing being tight in the arms and things like that. So then obviously the actual swelling might be another indication. And I think historically people have talked about lymphedema not being painful, but that's actually a bit of a myth. Lymphedema can be quite painful, and so we do know that people sometimes experience anything from pins and needles to darting, aching pains, or stiffness in the joints, and I guess that really, if you think about the swelling and as the body's changing, it kind of makes sense that these shifts would be causing discomfort. And even sometimes it can feel hotter than other parts of the body too.
Right. No, thank you for that, Debbie. So that gives everyone, I think, a really good overview of what to look out for, of being suspicious that lymphedema might be present. You mentioned before, John, the different types of lymphedema, primary and secondary, and then benign and malignant. How is lymphedema treated?
Well, lymphedema is treated often based on the stage as well. So when it's stage 0, that's what we call, the best thing is to find it early, and we use, you need to see a therapist before your treatment, have a baseline. We might do what's called a SOZO or LDEX measure. That's called bioimpedance. We want to find lymphedema before the doctor can even see it. So it's a bit like when you go and have a mammogram, you want to find the cancer before we can see it. When you can feel it and see it and swollen, you know it's getting more advanced. When it's stage 1, where you start seeing what Debbie said, that the rings might get tight, you might lose the grooves between your tendons or see some thickening around your elbow or some swelling of your foot, for example, then you need an accredited therapist to talk to you, and we talk about complex lymphedema therapy. Now, essentially that means skincare, exercise, education, massage, and compression. Compression is the most important thing to help the muscles move that lymphatic fluid towards the centre of the body and back into the veins again. And there's other treatments as it gets more advanced.
Sure.
Yeah. And it's interesting, if I might add, the compression, I think, is, whilst it's only one of those 5 components, it is the biggest one. And I think the thing that's interesting is there's constantly more and more parts to that treatment, and the treatment includes could be like getting the swelling down initially. So we do compression bandaging, which can shrink the swelling down. Because compression garments, you want to get them on when the limb's as small as it will go, because then it just holds it there and stops it getting bigger again. And people often say, what's the difference between those 2 treatments? So that's the bandaging to bring it down, compression to keep it there. But there's so many new compression types. It's not just the old school compression garment that everyone hates to wear. Actually, there's really good products being developed all the time. There are wraps which make it easier. There's lots of new fabrics and things, and there's even compression pumps, which mean that you don't have to be wearing it all the time, and that might be something that's really good for someone that can't wear a garment during the day.
Yeah, right. we often that's a really good point, and we often talk about the reduction phase. In America, they call it complete decongestive therapy. You decongest a limb by bandaging is the best way, but often difficult to access bandaging. It's inconvenient, isn't it, Debbie?
It is a bit, yeah. Yes. I used to do it in my uni holidays.
Right. And then once you get it decompressed, then you start moving from the therapist doing a lot of your manual lymphatic drainage to self lymphatic drainage, and less appointments, or using one of these compression pumps and sitting in front of a TV whilst the machine pumps your arm or your leg.
Yeah. But I love that, John, what you said about self-directed management. I think that's really key, when people can learn to manage the condition themselves, and that's something that we're quite passionate about, and I know that you are as well. So yeah, good point.
No, thank you. And that's a great discussion and interplay between the two of you. So thank you for that. And I think we're going to delve into, where people can access the therapy in the next few questions. But just before we get to that part of our discussion, John, just to go back to some of the medical aspects of treatment, you mentioned about SOZO machines to check for lymphedema. You mentioned about screening for it early, and of course you mentioned breast cancer. If we just focus on breast cancer for a moment, although of course, as Debbie and you have said, breast cancer is not the only disease that is associated with lymphedema, far from it, but just concentrating on a patient who is undergoing or about to undergo a journey of being treated for breast cancer, how should the diagnosis and management of lymphedema be integrated into that journey?
That's a big question. I guess the important thing is I often see a patient post-operatively where they haven't had any lymphedema checks. So I think it's really important that the oncologist ask them to see a lymphedema therapist, have a baseline check. If then have a check after radiotherapy and maybe every 3 or 4 months, depending on the risk. So if the risk is high, for example, if they've had an axillary clearance or if they've had radiation above the neck, above the collarbone called a supraclavicular fossa, then you might have a risk of 20 to 25%. That's 1 in 4 or 1 in 5 getting lymphedema. In that case, you want to follow it up more carefully. The other point, Ian, is, and we're doing a lot of this at Icon Cancer Centre, is being smarter about our treatments. How do we de-escalate our treatments? So we've gone from doing a lot of axillary dissections to doing what's called sentinel node biopsy. I know a lot of the listeners would have just had a single 1 or 2 lymph nodes removed and then avoiding an axillary clearance. So the fluid then circulates a bit more. But the other thing is radiotherapy, we can de-escalate that. We don't always have to treat the neck area. We don't always have to treat the whole breast. We can do what's called partial breast irradiation. And I'm using a technique where you can sculpt the radiotherapy away from the armpit if it's negative rather than shooting right through the armpit.
Right, sure. And is surgery ever a treatment modality that's used for lymphedema, John?
Look, I established the Alert Lymphedema program at Macquarie University, I think it was about 2012. And Dr. Helen Mackey, who's one of the sort of leading doctors in Australia, approached me and said, John, I'm looking for a patient. I'm looking for a doctor who can do liposuction. Right. And I thought she had rocks in her head, in terms of, we were taught not to stick a needle in an arm, not to do a blood pressure in an arm. And here we are, recommending liposuction. And well, I said, look, if you can find me an international expert, you can find me the evidence, find me a patient. Anyway, 5 minutes later, they found me the patient, international expert. We flew them down and had treatment. But this is my new book. But you can see, Sian found us on the internet, and she was quite young. She had 6 children, a primary school teacher. Her leg was 12.5 kilograms more than the other side. She couldn't sit down. She couldn't even go up 3 steps. And so we invited the father of liposuction, Professor Bråsen from Sweden, to help us with this case and teach us. And he said to me before the case, he said, John, I've never done one so big. And I said, well, we've got good plastic surgeons here. Let's give it a go. And so we did it. And there she is a few years later. She, in the story, in the book, she climbs the Harbour Bridge 3 months after treatment. So a friend said to her, I've booked the Harbour Bridge. She came to see us for an appointment and she filled a consent form. Have you had surgery recently? No. Have you got any medicals? No. Light through her teeth, climbed the Harbour Bridge.
Amazing.
And sent a message to Professor Bråsen, who then showed this video around the world and said, I've been saying this for years, that liposuction is not a cure. It gets rid of fat deposition. Lymphedema starts stimulating fat. It gets rid of the fat. People can then wear jeans again. They can wear a jacket again. This lady is an amazing story. She's now done a full marathon and 40 half marathons, and she couldn't even walk 3 steps.
It's incredible.
It's an incredible story, isn't it?
I think that's interesting, though, because what you were saying there about it's the volume reduction, and then she still wears compression, and does all her treatments and things. It's not a cure, but you can, if you can get that volume down, that's what was impacting her.
And there was a lot of criticism of this technique in the early days, and people said, well, it doesn't cure it. You still have to wear a garment. But the reality is, swelling is the biggest issue. You can't put a sock on, you can't put a stocking on, you can't put a compression garment on. There's an increased risk of cellulitis. So and it reduces the risk of cellulitis. There's other forms of surgery as well, in lymphovascular anastomosis, lymph node transfers, and we've done a lot of that at Macquarie Uni. But my advice to people is, take care. There's a lot of, surgeons doing it, but not working as part of a multidisciplinary team.
So the surgery is part of a holistic management approach to the patient, as you say, as part of a team, and surgery is only employed for a minority of patients. Then it's what you're saying, John.
Exactly. I think that's the main message, and I'm not sure if people saw that picture in the book there, because switching between you and Deb, I'm not sure if it's a technical problem, not seeing me, but it's the important thing is knowing. When patients came to see us for surgery, we tried to find reasons not to do an operation and look at more conservative treatments. We would do special imaging called ICG, which is like a fluorescent dye, to try to figure out which way the lymph is flowing and whether massage and so on can help.
Sure. No, thank you. That's a great discussion, and thank you for that illuminating case history. I mean, that, as Deb was saying, that really is inspirational. With the treatment services, going over to you now, Debbie, where can people access treatment for lymphedema?
Yeah. So, look, good question. I mean, that's what it's all about, really. It's the finding a good lymphedema practitioner. And I say lymphedema practitioner because not everyone that does lymphatic drainage actually knows how to treat lymphedema. Whereas if you found an accredited lymphedema practitioner, they've been sort of trained in lymphedema. And you can find treatment either, I'm going to break it down into public versus private, because unfortunately there is quite a lack of public treatment services out there. However, some public hospitals in Australia will have treatments available. It doesn't always say it on their website. Obviously, first look at the website and see if lymphedema is listed. But sometimes you can actually call up and ask either the physiotherapy department or the occupational therapy department. They're usually, either of those departments will have a lymphedema in it that not everyone always knows about. So that's how you can find out if your local hospital has a public service. And if they don't, they can sometimes tell you the next nearest hospital. But if you're able to afford or get assistance to do private, there's private lymphedema practitioners. And the Australasian Lymphology Association, ALA for short, their website has a system on it that you can find a practitioner. You can search by your postcode and see where your nearest practitioner is. And they can be found at lymphedema.org.au.
Right. No, thank you. Thank you for that. What about going on now, Debbie, to support services? As we've heard from both you and John, lymphedema is a chronic illness and the treatment is ongoing. There's a lot of self-management involved and garments, and it's not a matter of just having one treatment or an operation and the disorder being cured. It's an ongoing chronic issue, and we all know that with such chronic diseases, especially when diagnosis may have been delayed and the disorder is relatively rare, with many medical practitioners and health workers not being experts, that patients can start to feel isolated and depressed, and it can be a difficult journey. What sort of support services are available and would you recommend for people with lymphedema?
Yeah, thank you. I mean, you're quite right. I mean, lymphedema is not just a physical thing. It can be socially, psychologically, and financially. It can affect people's lives. And I guess I'm representing the Lymphoedema Association Australia, or LAA, this evening. And we certainly do have ability to offer some support. Obviously, there's not support groups everywhere, but there's certainly, jump online and have a look at our website. There might be some in your area. And we do have some online group for sort of more regional from a support point of view. We have a phone line that can help find services. Like if you're not sure, we can sort of help link you in with somewhere that might be appropriate. And whilst we don't offer individual advice, obviously we're sort of providing that support. We do give access to information, and so the Lymphedema Association Australia, we have newsletters, we run webinars on different topics and have experts speak on aspects. So it's a good way to kind of to link in and see what's the latest. And we also have informations days. I should actually do a plug. We've got in Fremantle on the 18th of May, on Sunday the 18th of May, we have a little in-person information day in Fremantle. So have a look online if you're in Perth or Fremantle. And in Sydney we'll have one on the 26th of July. So jump on our website and have a look. We do have membership for our association, which I guess the reason that's important is because it helps us give a voice to people when we do advocacy and raising awareness. We can say how many people we represent, and we can make sure we're listening to our members and understanding what they need. And I guess, when I stop and reflect, some of the biggest comments and feedback we get is actually after people have met other people with lymphedema, and they stop and say, wow, that was so good to just see other people living their life with the same condition and understanding how they cope, exchanging ideas and little tricks, and
Yes.
it makes a big difference.
Sure. No, totally understandable. Yeah. Very helpful. Who is eligible to join Lymphedema Association Australia? What do you have to do to be a member?
Anyone with an interest in lymphedema. So you might be someone with the condition of lymphedema. You might be a health professional interested in lymphedema. You might be someone at risk of lymphedema or a carer of someone, such as a parent. I think anyone really with an interest, we certainly encourage all, and you can, our website is lymphaustralia.org.au. So, and I mean, I think one of the things that comes up a lot in what you asked about, in having a chronic condition, and you mentioned doctors not always knowing, because it's certainly, I think it was one slide in medical school, and one of the things the LAA, the Lymphedema Association Australia, has done is try to increase that awareness amongst GPs. And obviously it's going to appear backwards on the screen, but on our website you can access under resources, there's a GP guide, and it's just a really useful tool to print out and take to your GP, because it summarizes all the things we've talked about tonight, and it also has a flow chart for diagnosis on the back, so that the GP can sort of help work out eliminate other things and work out if it is lymphedema. And that's been something that's been an accepted resource by the Royal Australian College of General Practitioners. So another reason to join as a member, because these are the things we're doing to create awareness and advocate for our members.
Fantastic. And certainly we really thank Lymphedema Association Australia for helping us at Icon Cancer Centre to put on tonight's Facebook Live event. And that's fantastic that you have such a broad membership, and that anyone with, as you say, an interest in lymphedema can join. John, just over to you now for the final sort of question before we go on to answering questions from the audience. And please, certainly it's not too late. If you have a question for Debbie or John, please put your question through the chat function. John, in lymphedema management, as we go into these questions, what is it that you would like to see change in the management of lymphedema in Australia in the next number of years?
Look, I think it's under-resourced. We need probably a Medicare item number for lymphatic screening, so to give incentive and rebates to therapists out there. We need more funding for garments, and we need liposuction surgery, for example. We can only do it in the private hospital at the moment, and patients have to pay because it's considered cosmetic, and it's not cosmetic. So I think, as well as making GPs more aware, and of course educating patients with my book, and what Icon's doing, the SOZO machine also measures body composition. Eventually patients on chemo will have a SOZO measurement, can look at their hydration, can look at their muscle mass, can look at their fat mass, and look at their lymphedema at the same time. That's the future.
That's a great segue, John, into our first question from one of our viewers, which asks if you could explain, John, what is SOZO? And I know we've mentioned it a few times, but just to take a step back and explain to the uninitiated, what is a SOZO machine and how is it used?
Look, there's a chapter in my book called Early Detection. I'm not sure if you can see that, but you can see it's essentially a scale. You jump on it, take your shoes and socks off and rings, empty your bladder. Takes about 2 or 3 minutes by the time that happens. And it then measures the amount of what we call extracellular fluid. And provided you're in the green zone, then we know that comparing the left and right limb, there's no excess fluid. But if it goes up into the orange zone or into the red zone, then we know there's some excess fluid there. At that point, we if it's gone up by about 6.5 or 7 units over baseline, we recommend an over-the-counter compression garment for about 4 weeks. Check it again and keep an eye on it. And in some cases, you can reverse it if caught early, and that's been proven by ICG studies.
Right. So the SOZO machine is available in various clinics and with lymphedema practitioners. Is that where people
a number of therapists do have a number of private therapists, and some of them will have the machine as well. And I think it's really the most useful when you're actually using it on more than one occasion for comparison, not just as is there fluid or not, but that what John was saying about having it before surgery, you can clearly see then if there's been changes and a difference. It's
a Queensland company as well, Ian. So
okay.
yes, and it's great that Icon's funded, I think, 13 in our centres. And it's quick, but not everybody's got access. Even if you don't, you can still screen using old-fashioned tape measures and volume measurements, but it's a lot harder. It takes a lot longer.
Yeah.
Right. Thank you, John. Another question has come in, and I'd like to put this question to both of you to see what you think and to see if there's any differences from the radiation oncology perspective to that of general practice. And that is, do you recommend any lifestyle changes or lifestyle treatments for lymphedema? So maybe we'll go to Debbie first and then over to you, John.
I mean, I guess the ultimate goal is doing what we can to not have to change lifestyle. We spend all our time trying to make sure people can continue their lifestyle. But I guess John mentioned earlier about the infection risk with lymphedema. Lymphedema is a protein fluid, and it's really vulnerable to infections. And so one of the biggest things that I recommend my patients is taking care, and any change to the surface of the skin, any breakdown in that surface barrier leaves you vulnerable to infection. So cuts, particularly when you're gardening, making sure, I still say get in the garden. I still get in the garden, but I make sure that I'm wearing long, sleeves and pants and gloves to protect my skin. And if I do happen to get a cut, which happens all the time, that I'm making sure I'm treating it early, whether I'm putting some betadine on or some antiseptic, and keeping an eye on it to make sure that it doesn't get infected. And if there is any infection, treating that early. So I think that, for an example, is one of those big lifestyle changes. Still do these things, but just being aware of those aspects is what's really important. I know that in the past, there's been lots of recommendations about what changes people can make. And excuse me if I say, back in the old days, they used to say, don't exercise, stop exercising, because that's really bad. But we know now from research, it's the exact opposite. You need to keep moving for the muscles to pump and help those lymphatics move. So, I think it's really important that with lifestyle, in fact, yes, we want to keep doing it. Maybe we make some tweaks here and there. And for me personally, for example, I've learnt that when I exercise, I'll often get in the swimming pool afterwards, because that cool water and hydrostatic pressure really helps my lymphedema after exercise. So, I think it's all about tailoring it to your individual experience. I don't want to modify your lifestyle to the point where no one should be not allowed to do something. And John's patient who was able to have surgery and have the volume reduced, we can do that with bandaging and compression if we get that early, and then you can run marathons. So anything's possible.
Yeah, I can add a little bit more to that as well. I think the Lymphedema Association of North America, after 12 years, has finally updated its guidelines in November. And there's a table in my book. I was very grateful to Cheryl Brunel, who's one of the best therapists in the world, who alerted me to the new guidelines. She was the primary author. And, in the past, poor ladies would wear wristbands and don't have a blood pressure, don't have a needle, don't do this. I've heard stories of people not going on planes again, fearful that flying would make it worse. So I think being educated, knowing that you can do most things. I always tell my patients who have lymphedema or at risk for lymphedema, I always give them a script for some Keflex when they go away, and give it and say to them, fill it out before you go overseas, put it in your handbag. So if you're in, overseas and you get a swollen red breast or a swollen red arm from cellulitis, you can treat it immediately, because you don't want to be in a situation where you get septic and end up in an emergency care somewhere. I think skin care is very important, as Debbie mentioned. There's ways of perhaps looking after the skin, moisturising it daily, and helping to prevent the infection, but not, as Debbie said, not to wrap yourself in cotton wool and not be able to do anything again. Occasionally I might say to one of my patients, when the husband's there, and say, look, I think you can't do any housework for 3 to 6 months. And the husband sort of look at me like this, and the wife saying, yes, good idea. But I tease them a bit. But look, you've got to give and take in relationships, but you can lift the shopping, you can do things. But if something's really heavy, I still think get some help.
Yeah. And that's it. Everything is tailored to the individual. Obviously, everyone's circumstances are different and their individual treatment experiences. And I think that's where it's helpful to have a lymphedema practitioner to be able to discuss those little nuances of your journey, and make sure that you get that, I guess, that you get a toolbox to help you through, and that it's right for you.
And exercise is really, really important, as Debbie said, not just for lymphedema. It helps that, it helps your bone density, it helps your heart health and recovery from breast cancer and other cancers.
And yes, no, well said. I mean, it's been shown, yes, across the board in most of medicine that exercise and staying active is very important, right through to, in primary practice, through to people having chemotherapy for cancer, where there are more and more studies now espousing and showing in detail the benefits of exercise at all stages of life, and even during treatments such as chemotherapy. What about, to both of you, the role of diet? Is there any special diet or any special foodstuffs that people should be following and
Do you want me to take this one, John?
Yes, please.
So I think it's a really controversial area. My personal opinion is keeping a healthy weight. So keeping weight down. And obviously we all know there's so many different diets out there. I believe in things that are sustainable and aren't going to be taking away too many food groups, because then that's going to start to affect other things. If, bone density, for example, if we're not getting the right things. So particularly looking at low carb and Mediterranean diet, those two are probably the ones I'd use the most, because they assist with weight loss, but also the maintenance. They show the least amount of yo-yo in diet. There is a lot of information out there about lymphedema and keto diet, and it's usually sort of a modified keto diet. But what I tend to find from my patients is they're finding it's not necessarily as sustainable. But there is some research, and particularly an endocrinologist in the US, Karen Herbst, she's sort of looked at that a fair bit in terms of diet and lymphedema and lipedema as well. And so that's something, if you're interested in more information, I'd go there. But in general, I would probably stick with a low carb diet. That's, you know, as a sort of a Mediterranean diet, and that's probably going to tick our boxes.
Right. Thank you. Anything to add to that, John, or you're in agreement with Debbie?
Yeah, totally. And I've written a paper where we looked at patients who gained weight after chemotherapy or breast cancer treatment, and those who gained more weight had more lymphedema. So it's sort of a catch-22. If you get lymphedema, you do less exercise. If you do less exercise, you gain weight. That makes the lymphedema worse. So it can be this real vicious circle. But yeah, I'm certainly interested in these new drugs that are coming out, the Ozempics and Debbie, what are those other ones called, the GL something or other?
There's a few out there, and obviously we don't have the research of that and lymphedema, so it will be only a matter of time before we start to see people, you know, on these medications, and then we can actually give, you know, well researched advice.
No.
Yeah.
Sure. It's a good transition, though, both of you have made from talking about exercise and diet over to some of the newer treatments, because it dovetails very nicely into a question that has been asked by one of our people watching tonight's program, and that is for you both, and maybe we'll start with you, John, and then go on to Debbie, to detail some of the newer treatments for lymphedema itself. I guess it's you've mentioned briefly some of those new drugs to treat obesity, but just going back to lymphedema now, John, what are the new treatments on the horizon for the future?
Look, I think there's hope out there, and I think there's no magic bullet at the moment. But I know there's surgery, I think, probably in the too hard basket. We've tried various anti-inflammatory drugs, even some, you know, simple drugs. Ibuprofen has been used. At Alert, we tried some anti-inflammatory drugs because you get this inflammatory reaction and so on. But there's no magic wand that I can think of, Debbie.
No, and when it comes to medications, that really hasn't been something that there's definitely been a lot of research but not that much progress. And I think to answer the question about that sort of new sort of treatments, I mean, most of the treatments around have been around for a while. They're certainly constantly adapting and getting better, and so taking the principles of compression, using it as a pump. We also use sometimes negative pressure, so pump being positive pressure. Negative pressure actually lifts the surface of the skin so that the lymphatics can flow under the surface better. So there are devices that actually do that process. So there's constantly these new developments, but I think the way I'm going to answer this question is say the most exciting thing that I feel that I've learned in the last couple of years is the volume of research going on in the lymphatics area. Like, lymphatics is having its heyday, and you know, scientists all over the world are doing more and more research in this, whether that be in the laboratory and at a anatomic level, or whether that be actually in the actual treatment area. People are finally paying attention and investing in that research. So to me, it's only a matter of time before big things come out of that, and we do have new treatments. I'm not saying it's going to be a cure, but I think it will. That's where we're heading when you look at the research that's being done. So I'm quite excited for what the future holds.
I think there is a new operation that people are trialling. It's still very early days. It's called a lympho operation, where if someone needs an axillary dissection, you bring in a lymphatic trained plastic surgeon to join a tiny lymphatic straight into one of the small veins as a bypass to try to prevent it. But the data is very early. I've looked at it. We don't know what radiotherapy does to those anastomoses and so on. But look, there is hope, and I think early detection is the key. And but I'm sure we'll find an answer in the next few years.
No, thank you. Yes, I mean, it's heartening to hear, Debbie, that the research is expanding in this area, and as both of you have emphasised, you know, for too long it was perhaps a forgotten area of medicine. And as you point out, when we were all in medical school, lymphedema really didn't get much discussion at all. So very heartening to hear that there's more and more research going on. Both of you have also clearly proposed exercise as, you know, a very important part of lymphedema management, and certainly John's case study illustrated how exercise can be performed in people with lymphedema, although also the case history emphasises that proper management, detection, therapy through an accredited practitioner, have the condition as controlled as possible, and then people will be able to exercise, which will then have the many positive effects. We're really out of time. It just goes to me now, as we thank both of our speakers, as well as, of course, everyone watching, just to, first of all, throw to Debbie for any last words on lymphedema, and perhaps again just outlining to people how and where on the internet they can get information on lymphedema, both from the Lymphedema Association of Australia and other sources.
Yeah.
And after your final words, Debbie, I'd love to then just throw over to John to hear his final thoughts on lymphedema, but also to tell people a bit about your book, John, the lymphedema book. You've written quite a number of books, including books on vaccination after cancer treatment, now lymphedema. So after Debbie wraps up, I'd love you to espouse to the audience where to get your book.
Sure, thank you.
Okay, so I guess my take-home message is, if you make me put it in a neat little, I think the main thing for me is making sure you've got a lymphedema practitioner that you work together with, and discuss your treatments and different options, and just really create a toolbox for yourself, and then there's lots of options. And you know, as one of those tools is looking at where the resources are. So Lymphedema Association Australia, check out at lymphaustralia.org.au, have a look at our website, feel free to join as a member and see what's available. We have a library of webinars that you'll be able to have look through, and some resources. And if you're looking for a practitioner, there's the Australasian Lymphology Association, which is lymphedema.org.au, and they have a find a practitioner button, and you'll be able to search there.
Right, thank you, Debbie.
Well, my take-home message is join the Lymphedema Association of Australia, because I think I'll be joining. I didn't realise it was available for health practitioners. Information and education is really important. Don't get patronised about your lymphedema. That's what really annoys me, when a doctor might say to you, well, that's the price of, you know, curing your breast cancer. Well, it's not. It's a matter of finding it early. And of course, I'm passionate about lymphedema. This book's been read by the best experts in the world, peer-reviewed. Leanne Moriarty's given an amazing endorsement. It's taken me 3 years to write. The royalties go to the Alert Lymphedema program for research, and it covers early detection, treatment, everything. And it's getting rave reviews around the world. And thanks for telling people about it. And thanks, Ian, for being an amazing host.
No, fantastic. And congratulations again on the book. John, where can people purchase the book?
Look, there's two ways. You can go to the book's website, BC for breast cancer, bcpublish.com, or to Amazon. And you can get it on Amazon, iTunes, Google Play as ebook as well. Some people prefer an ebook, or you can get it sent out to you. And I think it's $39.99. And if you type in alert, I still think you can get free postage. I'm not sure how long it'll last for, but alert, ALERT.
No, thank you. Well, that is certainly time now. It comes to me to close the session. Thank you again to Dr. Debbie Geyer, Professor John Boyages, for joining us for tonight's session on lymphedema. It's been a fantastic session. I've certainly learnt a lot, and as a haematologist, this is certainly not my bread and butter, but I found the discussion illuminating. I know everyone watching will also have enjoyed the session. As I mentioned earlier, there will be a recording of the session put up on the Icon Cancer Centre Facebook page, so please share the link. We'll also have a link from tonight's session to places to purchase John's book if you're looking for another way of how to find John's book. Again, thank you to everyone tuning in and for making Icon Cancer Centre's Facebook Live series so successful. We believe passionately at Icon Cancer Centres of educating everyone around the country, patients, carers, practitioners, as much as possible about cancer and related topics. So thank you all for helping make the program such a success. Thank you to Phil and Maggie at Icon's end for the technical organisation. And we hope to see everyone again at our next session over the year. So good night to everyone. Thank you again, Debbie and John.
No, thank you.
Thank you. Good night.